Assalamu alaikum. Thank you. Thank you, Abdullah, for your kind introduction. My job is very easy because Misbah asked me to talk on IDF MENA region guidelines. Are they special? What is special in it? So I thought and came with an answer. No, nothing is special. So my lecture is done. I've got 14 minutes and 58 seconds still because there's nothing special. And I could never comprehend what do you mean by saying special in a guideline. Guidelines are just guidelines. Then I thought, okay, make it less special, but say something because 14 minutes are a bit of time. And I'm not good as our brother Nabil is by telling about news, history, and others. So I just thought that I'll select some excerpts of this guideline. First thing is these guidelines are solely designed to cover the management of type 2 diabetes. It has nothing to do with type 1 diabetes. The guidelines for type 1 need to be developed for MENA region. Today's session, I was interested in the workshop, which was completely in Arabic, and I was trying to follow the Arabic, as always, with the Quranic Arabic, and trying to find out if I can understand few words of it, and I did manage to. It was a very good workshop for type 1 diabetes. Gestational diabetes, we have got experts like Nadima and Shabeen sitting in the audience. हम उर्दू में तो कहते हैं बाबाए मेडिसिन what do mamae medicine mothers of gestational diabetes they have developed a very comprehensive document special situations like Hajj and Ramadan Yaqub is there now fasting and diabetes has been made a group with Dr. Mujahid leading it with co-lead as Yaqub. So these guidelines are not covered in this document. The committee, I was given the honor to be chairman of the committee, and we had a very comprehensive guidelines committee who did this job. These are the contents. So the contents again are as usual for all the guidelines we see across the globe. Again, nothing special in it. The only thing which is special, and I'll touch on later as well, the recommendations for referral from primary care to secondary care to tertiary care and vice versa. And I think I'll take this time right now to say that unfortunately, we do have data, we do have guidelines, we do have documents, we do go to conferences in ADA, ESD, etc. When it comes to practice in our parts of the world, there is the pinch of salt, that are we really doing what we know? Is there a system of primary to secondary to tertiary care referral or not? Are we planning to implement it, execute it, etc., etc.? Right, MENA region have got diabetes. Epidemiology, the numbers are scaring. 1 in 6 adults have diabetes. 73 million. If I am not wrong, that MENA and Southeast Asia are the main capitals of diabetes and include China from Western Pacific. 2/3 of the diabetes globally is being catered by these two regions. 1 in 3 people are living undiagnosed. 1 in 7 live births are affected by hyperglycemia in pregnancy. Lot of economic implications as well for this number of diabetes. These guidelines are evidence-based on available local, regional, and international scientific information. The other thing special in it is they consider affordability and availability of medicines in the MENA region as well. As I said, that this maintains the referral system from primary to secondary and tertiary care and vice versa. It gives the concept of developing multidisciplinary care teams. We in Pakistan are struggling to have multidisciplinary teams, even at tertiary or secondary care level, not to talk of primary care level, but this ought to be there if we want to standardize diabetes care at all levels. These recommendations will be revised every 3 years. By the time recommendations are developed, guidelines are developed, they already are at least 1 year old. If they are not, that means that literature search has not been comprehensive. So you developed a document, it will already be 1 year old. You write a chapter in a book, it will already be 2 years old. And so it has to be revised and re-revised. What we suggested to that these are only guidelines. Individualized approach according to specific scenarios are still key to the management. And in MENA region, you can imagine countries like Pakistan and Afghanistan with very, very low GDPs, and Yemen, for example, and with My friend sitting on the podium, Qataris can't talk of the GDP at all. I can't even calculate the amount of a GDP of a person in Pakistani rupees. It goes to millions or something. And then we have got in middle like Iran and Egypt, other countries which are not perhaps that high income, but not low income either. So it has to be stratified according to MENA region. And if I am not wrong, and Banshi may be able to bear me out, MENA region in this regard is the most diversified regions amongst the IDF. If you look at North America, USA and Canada perhaps sharing the same economy, they have a problem with the Central America. South America has almost the same-ish economy. Western Pacific region is almost developed to a large extent, may it be Korea or China or Japan or Australia and New Zealand across Pacific. But when it comes to MENA region, it is very diversified as regards the healthcare systems, as regards the GDP, as regards the governmental involvement. Okay, referral criteria, as I said, this is the definition of a primary care. The primary care shall have all these done with the patients. The secondary care level has multidisciplinary approach, and they should be led by a physician. Again, what ought to be there in the secondary care is covered here. Tertiary care, a university-based teaching hospital, comprising of an outpatient, inpatient, integrated care, along with research and education programs. And I have been given this job today by my predecessors, and the founder is also here of DASG, Professor Mursi Arab. Also credit goes to Professor Abdul Basit, late, may Allah bless him, bless his soul, who developed this idea of DASG. We in Diabetes in Asia group and in MENA region shall concentrate on this referral policy. And I remember Professor Mursi Arab telling us for the last 20 years, if I'm not wrong, that please develop national diabetes programs. They shall be developed on a country basis. May it be in a private sector, may it be in public sector, depending on the economy and the healthcare system of that country, but national diabetes programs ought to be developed. Then we decide what shall be catered at a primary care level, secondary care level, and tertiary care level, and vice versa. Unless we are able to do it, at least in Pakistan, having 33 million people with diabetes, we cannot cater in any healthcare system whatsoever with the given resources. Unless we develop such kinds of programs, we develop peripheral clinics, we develop nurse-led clinics, etc., etc. So this is tertiary care. Population screening. I was just dictating a letter today in my room in the morning as regards running a primary prevention program. In Pakistan, you cannot do biochemistry of millions of people. You ought to have a non-invasive scoring system to screen the high-risk subject for type 2 diabetes. It is almost mandatory, it has no choice but to screen people for type 2 diabetes without involving biochemistry. There is one more thing special as regards HbA1c. Can we use HbA1c as freely, as officially, and as successfully as is used in Europe and America for that matter? I think we have to have this line, and between this line there are lots of other hidden lines. A standardization in performing method of HbA1c. It is still questionable. At least in Pakistan, I'm sure the same happens in Afghanistan, in Yemen. I don't know about Egypt, to be honest, but I know in many countries, HbA1c standardization is still not there. And I can tell you with certainty, at least in my part of the world, that we still having labs who are doing HbA1c by doing the fasting glucose and calculating it accordingly, by doing a HbA1 and calculating it accordingly. So we have to be very certain that the standardization is there for the diagnosis. The other part of the guideline which is so specific is self-blood glucose monitoring. We have developed it as per the BRIGHT guidelines developed in Pakistan to start with. Lowest intensity, moderate intensity, high intensity, and intensive intensity. This is a document which was being published before. Now it's part of the guidelines and again being published. So it's important to consider in it affordability as well, apart from frequency as per the scientific evidence. The classification is there. I was just listening to Professor Mohan, and he had a wonderful talk given on these new classifications the idea coming from Sweden. And Mohan was right in saying, and which we missed out, that for the last 30 years we have been saying the same. In the past, there was fibrocalculus, pancreatic disease. There was MRDM, malnourishment related diabetes. These all were there. They were made extinct. Came type 1, type 2, autoimmune, etc., and now again coming back to the old pathology. I have my own ideas about this classification, but this classification, as I admit, that the guidelines, maybe in the next revised guidelines, we'll be talking about the new classification. These are assessment of glycemic targets, nothing new, nothing special in it. The non-pharmacological management have already been discussed in the sessions. Again, nothing special in it, so I'll just keep telling. I'm just showing this slide so that nobody in the audience thinks that the guidelines are not comprehensive if they have not seen the document. They have everything covered what the guidelines should have, but I'll just touch on the special things. Pharmacological management, the overview is there. Factors affecting management strategies. There are clinical factors, which again have been illustrated by my predecessors in various sessions, especially in the workshop it was done today. I must admit, Misbah, that when you talk, you not only talk, but you also want us to say that we have to say yes to everything you say. And everything you say, we have to say yes. We cannot say no to when you say something. So this was very authoritative, the workshop was. There are clinical factors, there are pharmacological factors, and then all the drugs we have got, the orals and the insulins. Obesity and diabetes is there, hypoglycemias, hypertension, dyslipidemia, foot disease, microvascular complications, neuropathy, etc., etc. So all is there. Rapid score, a screening test for diabetes. I would request many in the audience sitting to please try to replicate it. IDF has tried to make a global assessment risk score, failed badly because you cannot. So each ethnicity will have a different score perhaps. This is for Pakistan and it's working nicely and we have validated it quite a few times. This score we are replicating for our primary prevention program which we are going to run. The finalist slide is regarding the pharmacological management, and then the same as table-wise we go for optimized dose of metformin and then sulfonylurea, DPP, GLP, SGLT2, intensify insulin. And here I must admit what I was about to say if I would have had question chances with Mohan, that we in the past used to say and teach our students there's nothing mild diabetes. Don't label as mild diabetes. Because once you label some patient as a mild diabetes, then he goes home and enjoys sweets, Well, I can see yesterday in the dinner or day before yesterday, all sitting on the table, even they have diabetes and they were enjoying sweets. So what to talk, they say mild diabetes. So 20 years it took us to clear the concept there's no such thing as mild diabetes. But again, it is coming back, so history repeats itself. They now say mild diabetes. What we teach our students, and I like to have the same message for the PGs and the GPs in the audience. You are seeing a type 2 diabetic, as soon as he starts losing weight and 2 or 3 orals are not controlling him, please put on insulin. If he comes with a rapid weight loss day 1, you are in doubt whether this is type 1 or type 2, please start insulin. The threshold to start insulin shall be lower. Regardless of you are trying to find out what actually is the C-peptide or whether he is type 1 or type 2, he is part of MODI or LADA, the first thing is to save the patient. Especially I'm talking of family physicians who are working in remote and peripheral areas. They don't have access to hi-fi blood testing. Please go for insulin earlier than later. Right. Again, at the end, I would like to thank all who have participated in the development of this document. These guidelines are solely designed for type 2. These recommendations will be revised every 3 years. Any major changes in the intervening period can be included as addendum or corrigendum. I am very grateful that the whole team did give their inputs, which was repeatedly challenged and criticized and drafted before finalizing it. And I'm also very grateful to Mohan and JOD for accepting in publication. These are the national and international collaborations, I think this is Karachi. And I take this liberty to invite all of you to 25th, 26th, 27th of August, when we are having in Karachi National Association of Diabetes Educators FootCon. Please remember this date. All of you are welcome. And again, I would like to thank the organizers, Misbah, Adil, and others for their warm hospitality. Thank you for your attention. Thank you.
Thank you.